Ladies and gentlemen, good morning. I'm Ahmed Ali, Assistant Lecturer of Vascular Surgery, Mansoura University, and today I'm going to present the van der Waal technique. In complex aortic repairs, a crucial part of fenestrated and branched repair is bridging the target vessels, whether the mesenteric or the renals, but challenges are always, or almost always, often found when the target vessels are prone to anatomical or pathological factors, such as the tortuous courses, calcification, thrombosis, stenosis. These are examples of the patients that we face in our daily practice. So, how to bridge those vessels safely and effectively to ensure the complete and the optimal endovascular repair. We have three options: the endovascular intervention, open surgical repairs, and hybrid solutions. So what are the most common reported techniques for endovascular therapy? That's the balloon anchoring technique. Cannulation has to take out, cannulation of the antegrated axis has to take place outside the main body device using a femoral axis and trying to anchor that wire with a balloon. The authors have reported that as through the branch technique. There is the snare ride technique, which instead of using the balloon to anchor the wire, they use a snare, but both of them still have to use another axis, and both of them have to take cannulation outside the main body device, and not taking into consideration that the aorta might be narrow at the level of the renal vessels. So a third option is the standard stabilizing technique, where a through and through is being established between the upper and the lower axis to regain more stability for a better introduction of the guide wire and catheter, but still does not effectively address the challenges we face with the ostia. We have the hybrid techniques, where you could do through open means a retrograde target vessel cannulation, but this would increase the mobility and the hospital stay. And of course, we have the open repair with the extra anatomical bypasses. So what about our van der Waal technique? It is available using off-the-shelf devices. It is economic. It is an endovascular solution entirely. It's accessible through one axis alone, either the upper alone or the lower through a steerable sheath, and is safe. With less risk to device integrity and the wall integrity and the sealing outcomes. So for today's case that I'm going to present, we have a patient who comes with an endoleak type 1A after a standard endovascular aortic repair, and we needed to do a more proximal aortic coverage. So we opted for a 4-branched EVAR device. We have a left renal artery stenosis with thrombosis. A standard wire was not possible to gain enough stability for an exchange and the delivery of a bridging stent. So after passing one wire, O14, we passed another wire, which is an O18 wire. That gave us increased stability, through which the catheter was able to be introduced into the left renal artery, exchanged with the stiff wire, Namplats. The bridging stent was delivered. This is an angiogram showing an effective bridging therapy of the left renal artery. This is an illustration of the two wires behaving outside the catheter. This is a very simple and homemade video we have done in our lab, showing that one wire was not enough to gain stability, but using two wires was enough to pass the catheter safely into the target vessel. And we were able to publish this earlier this year, the van der Waal technique. You're all welcome to have a look at it when time suits you. And thank you very much.